Hi, everyone. Sorry.
Hi, Dr. Huda. How are you?
Good, thank you. So did you discuss anything together or you just took it as a break?
We just kept quiet.
We took a break. I took.
Good, good. Okay, that's good. So what were we talking about? Remind me. Um,
I
The
think
cutoff
time to
point.
event,
Yeah, the cutoff point, right, from A to B.
time to event analysis. I think we were discussing.
yeah, we finished the curve, right? The cutoff points, we finished that, right? And then we were
Yes,
talking
yes.
about, yeah, the time to event analysis. Okay. Uh,
We can't see your screen.
okay, yeah, I will share now. Thanks for letting me know. Share screen and desktop. Okay, so you see the whiteboard here, the Google document.
Yes.
Okay. Okay, so here, yeah, so we were talking about the 80% of the death rate, right? Or the survival analysis, right? That's not
Yes.
okay. So we said you might have, the pen is not working. The pen, just 1 second, guys. For some reason, the pen is not working. So, okay, that's fine. I can use my finger. So here we said like the investigator, after he saw that 80% in the A group and also 80% in the B group died at the end of the 2-year period, he told you that treatment A is better than treatment B. So the idea here that usually when you do the survival analysis, in the survival analysis, we don't calculate those who died or the mortality rate like at the end of the study. We don't calculate during this two at the end of this 2-year period, because if you do that, that's what you will find. You will find that none of the treatment was like, or both treatments have the same survival rate. So when you do survival analysis, it's better to do what is called the time to event analysis. Time to event, you have to calculate the time to event. Okay, so you have to do time to event, which means yes, at the end of the study 80% died, but when you compare, when you do the time to event analysis, you will see that your study started here, for example, at this time, and for drug A people they were here, and for drug B people they will hear, and then over the time, like people were dying in this group. Okay, and then in this group people were dying like that. So if you calculate the time to event analysis, you will usually from 50% here, you will take this, and then you will calculate here. You will see, for example, like you will see in group A, in group B, people died at 3 months, while in group A, let's say people died in at 16 months, let's just say. So when you do the survival, the time to event analysis. So the time to event analysis, you are calculating the median survival. So you will see that the median survival in group A, like in group A, people died like around 16 months. So they lived longer, right? While in group B, the median survival, it was, let's say, 3 months. So something like that. So that's why we don't, when you're doing these studies to analyze the survival, when you're doing survival analysis, you don't check at the end of the study period. You are checking when you're involving the timing of the event, when this death happened. So then you will see the median survival and compare between this group. That's why in group A, the investigator told you that treatment A, it was better than treatment B. Although at the end of the study, 80 died. Why? Because the timing of the death, it was longer in those who took the treatment A than when you compare it to those who take treatment B. So this is the idea of the time to event analysis, and or what we call you're calculating the median survival. That's it. That's all the important things, and everything like I told you today. It's not, of course, I will not be able to cover everything, but I try to cover everything, the most important concepts. And as you see, like it's correlated from step 1 to CK and step 3. But if you have like any specific question for the remaining time that you want to discuss, just let me know and we can discuss it right now.
So with this thing, the time to event analysis and the hazard ratio are like they're the different. How do you differentiate? It's not the hazard ratio was involved here.
Hazard ratio, you're not incorporating the time of the event, right? You will just, I think you will do just at the end of the study, you will see the risk in the exposed and the risk in the unexposed, and then you're going to calculate the hazard ratio. So if you're having treatment A and treatment B, and you're talking about any hazard issue or side effect that happen, like in your group A, for example, if you're having 20 people in this group and you're having 30 people in this group, and or 20, let's see, like just the same, or 1,000 here and 1,000 here, you will see what is the number of people who get the side effect or the hazard in this group. So if you say like here is 5, and then here only just 1, and then you will do the ratio of this divided by the ratio of this, and you will calculate the hazard ratio. So if I told you what is the hazard ratio in A compared to B, so this means you will take the ratio of this one, if it was, for example, 0.5, I'm just giving random number, divided by this one, which is 0.3, for example. So this is the hazard ratio. But if I told you what is, if the hazard was here more than here, and I told you what is the hazard ratio in this group compared to this group, then this one will be the numerator, B will be the numerator, and A will be the denominator. And we're not incorporating, it's not like the survival analysis or the median survival. Median survival, you're just taking at 50%, you're seeing how many patients died or survived at this point. The time, we call it time to event analysis.
Okay. So I have two more questions if I can ask you, please. One is like the attrition bias, and then one is the intention to treat. Like when you are giving the results with the intention to treat, then why is the attrition bias happening? What is the difference?
In attrition, let me see.
It's like people are leaving the study, right? In attrition bias, then the results are biased. But in intention to treat, we still give the result because we are thinking about like our intention was to treat the groups. And
yeah, I know what you're talking about. You're talking about the intention to treat versus the per treatment or per protocol analysis in terms of the selection bias, right?
yes, yeah.
That's what you're talking about? I'm still trying to make the pen working, but it's not. So in the intention to treat and the per treatment analysis, there are so many questions that you can have about these things. First of all, understand the concept of that. So you have intention to treat and you have the per treatment. per treatment. Okay, so the per treatment analysis, or what we call the per protocol. Per protocol. Okay, so the per protocol. So in the intention to treat, what is the purpose of it? I can give you a question and I tell you what is the purpose of the intention to treat. So the intention to treat purpose, it always, you have two sentences to memorize. Number one is that you will preserve the randomization, preserve randomization. Which randomization? The initial randomization, you will preserve it. And also the result that you will get, we call it a conservative. So you will get a conservative result of what is truly happening in the real population. So this is kind of conservative analysis in the intention to treat. In the per protocol, you will lose the benefit of the initial randomization, and you will, another word here, we call it, this is more realistic, and this is unrealistic. This is unrealistic or less realistic in here. So the idea here, if I have, and there is in 2CK, they explained it in a table in a very nice way. So if I have 10 people here in my study and 10 people here in my study, and this is this is the initial randomization. So initially, my initial randomization, I give these people the treatment and I give these people the treatment. So this is my initial randomization, right? So initially, that's what happened. And this is what happened during the study. So during the study, you might have people who are not compliant or people who lost during the study, right? So if among these people who took the treatment, I lost 3, okay? And at the same time, those who developed the outcome of interest, they were 2, okay? And here, same thing in this group, if I lost 3 people, and those who developed the outcome were 2. So when if I did intention to treat analysis, in intention to treat analysis, we said you are preserving the initial randomization. So you will say that 2 people developed the outcome. So this is the intention to treat. 2 people developed the outcome out of the initial randomization was 10. So 10 people who took the treatment, right? Regardless to what happened here, regardless whether they were compliant or if they were lost to follow up or if they did crossover, if they took by mistake the other treatment, whatever happens during the study, you don't care. You are caring about what is the initial randomization. So 2 people developed the outcome out of 10. While here, if you are analyzing based on the per protocol, you will say 2 people develop the outcome out of 7. So you did not include these 3 who died, who didn't follow, who were not compliant with the medication. And also you did not include those who lost to follow-up. So you will say only 11 to 7. So what happened in the per protocol or per treatment, it means you're analyzing the data per what happened during the study. So what happened during the study? Did you take the treatment? I will include you. You didn't take it, I'm not gonna include you. Where you lost, I'm not gonna take you. Did you take the other treatment? I will analyze you in the other treatment group. So I totally forgot about what I did initially in the randomization. So why do we call this one is realistic and this one is unrealistic? Because in real life, this is some kind of a typical scenario. It's a very typical, conditions that everybody who's taking the intervention was compliant or not compliant, because I already analyzed those, which means I only analyzed those who were compliant. So it feels like this is a very typical situation in which everyone who's taking the intervention, he were compliant. But this one, I'm going to take everyone, include everyone. And that's what really happens in reality, because in reality, when you give the treatment, some people will be compliant, some people will not. Some people, they might, cross over and all these things. So this gives you kind of more conservative way of analyzing the data or of what's truly happening in the population, which is more realistic. And in addition, you are preserving the initial randomization. The other thing that you are talking about, which is selection bias. Selection bias, it happens with the pair treatment, because usually when you are not including in this analysis, when you're not including those who were exposed, when you're not including them in your analysis, usually, or maybe probably, highly probably, that those who were not compliant are those who are having more, who were in the exposure group, or in the treatment that you were interested in, or they were those with the who have the more severe severity of the disease. So if you are comparing, for example, if you want to test two types of shoes, one group who are taking one type of shoes, and the other group taking two types of shoes, or a shoes in addition to another thing that you add to the shoes to improve scoliosis or any bone disease, for example, or bone pain in the leg, or whatever the outcome is. Maybe those who did not, who were not compliant with the combination of your intervention, the one that you are interested with, maybe those who are having more severe pain or more severe of the disease. And when you are excluding them from your analysis, you are falling in the trap of having an attrition bias. Because what is the definition of attrition bias? You are losing patients during, like you're losing patients to follow up, or patients who are compliant to the disease. And usually these who are lost, they will be from one group, whether they are more exposed or they have more severity of the disease. Like if we give the example of smoking and lung cancer, maybe those who were not, who did not finish the study, or they lost, or they did the crossover or whatever, maybe they were those who are smokers, or those who are having the lung cancer. So when you are excluding them from your analysis, you will, this will lead to the non-differential, right? Non-differential loss of this sample size. So this non-differential, which is from the exposure or from the outcome of interest group, it will give you the selection bias or the attrition bias. Because if you're losing in the control and in the cases, like equally in both groups equally, this will just minimize your sample size. But if you're losing patients only from the more severe disease, or from the outcome that you are interested in, this will lead to the attrition bias. So when you are doing the intention to treat, you're not gonna have this type of bias. You're not gonna have the selection bias or the attrition bias. You will preserve the initial randomization, and your result will be more conservative of what truly happens in the population. Maybe you will not get a positive or a statistically significant, result, which is that this thing, the intervention that you did, maybe you will not get an outcome that the intervention was helpful, or it was better. But still, the outcome that you will get, it will reflect what truly happening in the population. This is just a summary about everything related to the intention to treat and the per protocol analysis.
Yeah, thank you so much. It's
Welcome.
clear now.
Anyone else has any question?
I have one more. If anyone wants to ask first, I'll go afterwards. Then.
No, go ahead. No problem. I'll ask after you.
Okay. So my other question is about the the positive predictive value in the question the patient is asking about. What is the positive predictive value, and then how can I differentiate it from if the patient is asking about the positive likelihood ratio? I mean, just to make it clear.
Positive likelihood ratio. Positive likelihood ratio. The question will tell you what is the likely. No. In the this is related to the definition again. What is you're talking about? Positive, about the predictive value versus the likelihood ratio, right?
Yeah,
what you're asking.
positive
Okay.
predictive.
Again, again, it's about the definition. Do you know what is the definition, or you don't know what is the definition? So likelihood ratios, again, because in the beginning we said, we talked about incidence and prevalence, right? So going back to that point, we said like usually prevalence, when you are having a more prevalence of the disease in a population, like if I'm gonna check the HIV status in a certain population, okay? And I came with a test, okay? And I told you we have two population. We have town A and we have town B. Okay, we have two population, and the prevalence of IV drug users in this population is higher than in this population. And then I asked you, is the incidence going to be affected? Is the prevalence going to be affected? And the predictive values. We know always that prevalence only affect the predictive values, but it does not affect the incidence of the disease or the prevalence of the disease. Why? Because it does not affect the sensitivity and the specificity. So we're talking about sensitivity and specificity, and we're talking about the predictive values. Okay, so if I'm talking about a prevalence, that the prevalence in this community is more than the prevalence of the disease in this community, sensitivity doesn't have to do anything with that. Specificity doesn't have to, it's not going to be affected. Why? Again, because of the definition. The definition of the sensitivity and the specificity, it's about your test. It is about the quality of your test in detecting the disease and in detecting healthy population. It doesn't matter if your population is having higher prevalence or not having higher prevalence. If you're having higher prevalence, the positive predictive value will be effective, and also the negative predictive value. Why? Because if in this town you're having a higher prevalence of HIV disease, and I came and I tested you and you were positive, what is your positive predictive value? Your positive predictive value here, it's high. Why? Because positive predictive value definition, it is what is the probability I truly have the disease if I get a positive result. So if you are in a population who has a very high prevalence of HIV and you get a positive result, yes, your positive predictive value will be increased because you you truly have the disease. Same thing with the negative predictive value. Negative predictive value here, with increased prevalence, it will be decreased. Negative predictive value, because usually if you're having a true result, a positive result, it means you do have the disease. And if you're having a negative result, it means that this result could be a false negative result because you're having a high prevalence of the disease. So always predictive values, they are affected by the prevalence. And usually these questions, they don't ask you straightforward. So I can ask you straightforward. I tell you the prevalence of the disease in town A is higher than town B. Which one is going to be affected? And I give you incidence, prevalence, positive predictive value, and relative risk, odds ratio, so many things I can give you. The only thing that gets affected with the prevalence is the predictive values, whether it is positive and negative. And how do you know? Always just write prevalence like that, prevalence, and make the positive predictive value as the numerator, or like as an association. This is the positive predictive value, and this is the negative predictive value. And when you review the questions, you will find so many variations in the way they ask. One of them, it's very like complicated, in which you have to know like the wording of the question and the answers. It's very confusing, although you are understanding the concept. So understand, just write this one, understand that if the prevalence is high, positive predictive value will be high and negative predictive value will be low. If the prevalence is low, which means positive predictive value will be low and negative predictive value is high. And I don't remember, but I think in 2CK there is a question which is everything is okay, and you will know that this means that the prevalence is higher in this population and the positive predictive. But when you read the answers you can eliminate, and you can come up with two answers. The way they worded the question, it was you need to think about it. Which one does it, what does it mean? So one of them, they put it in a negative way and the other one in a positive way. So you will exclude one and you will come up with one. But it's still, it will take you time to figure out what does this mean, which means like they're talking about the negative predictive value. And we know that by improving, by having a higher prevalence, it means that the negative predictive value will be low. So just understand this concept and apply it to any question that you see in this term. And then we said, so the prevalence, the predictive value is the only one that gets affected. Okay, what about the likelihood ratio? Likelihood ratio, what is the definition of likelihood ratio? Likelihood ratio, if you read the definition, it is the probability of getting a positive result in a disease population divided by the probability of getting a positive result in a non-disease population. This is the positive likelihood ratio. So again, it seems that in the likelihood ratio, you are talking about the test. You're not talking what is my probability that I truly have the disease. That's why the equation for the likelihood ratio, sensitivity divided by the specificity, right? If it is positive, it will be divided by 1 minus specificity. And if you're talking about the negative likelihood ratio, it will be 1 minus sensitivity divided by the specificity. So sensitivity always numerator, specificity is denominator in terms of the likelihood ratio. If it is positive, you will put the minus down. If it is negative likelihood ratio, you will put the minus up. So 1 minus sensitivity. So likelihood ratio, you are saying what is the probability here, if it is positive, that I'm gonna have a positive result if I do have the disease, divided I'm gonna have a positive result if I don't have the disease. Negative likelihood ratio, what is the probability I'm gonna have negative result if I do have the disease, divided by the probability I'm gonna have a negative result if I don't have the disease. So again, it is about the test itself. So how to differentiate between them two? Simply, like if I'm telling you what is the probability that I will have a positive result, this is likely that I will have a positive result. This is about likelihood ratio. But if I give you already, if the question, you always in predictive values, they give you either a positive result or a negative result. So they tell you someone did fine needle aspiration or urine analysis or whatever, and you get a positive result or you get a negative result. And next, what is the probability, the patient is asking you, what is the probability that I truly have the disease? So this positive predictive value. Or what is the probability I truly don't have the disease? So this will be negative predictive value. So we're talking about the reality of having the disease when you already have the test. But for the likelihood, you haven't had the test yet. It's the probability of having a positive result, or the probability of having a negative result, whether you do have the disease or not having the disease. So if you know the definition, you will be able to solve these questions.
All right, thank you so much. So it's like predictive values are dependent on the prevalence, but likelihood and the specificity and sensitivity is a function of the test that you
Exactly.
are performing.
Exactly. Yes. And because sensitivity and specificity, it is included in the equation of the likelihood ratio. That's why likelihood ratio, it's not affected by the prevalence of the disease.
Okay, thank you so much.
Welcome.
Dr. Huda, I just wanted to know how to approach the ad question. Like, is there a technique or depends on the question itself?
The drug ad?
Yes.
Okay, for the drug ads, just 1 second. For the drug ads, you approach it like you're approaching any other question. Don't read everything. Don't read everything in the question. Like you will, what you're gonna do, simply, you will have, for example, a very long question, and then you will have the ad that you want to open. So simply read just the last line. And when you read the last line, make sure that you understand what they are asking about in the last line. If still you don't know, don't read the question from the beginning. Look if for the paragraph that has, for example, values like p-value or whatever, or just jump one more paragraph up. Don't read everything. This is if it is a very long question. But usually they give you what they want from here. From the last line, last few lines, 1 or 2 or 3, you will know what they are asking you about. So sometimes they ask about number need to treat. Sometimes they ask you about the relative risk. Sometimes they ask what is the type of the study. Is it case control? Is it cohort? They will ask you to calculate the attributable risk reduction or the attributable risk percentage. Sometimes they ask you, they give you the answer, it will be sentences. So always in drag add, first step, read the last line. Second step, look for tables. If there are tables or diagrams or if there is any visual things like the tables, just look at the table and then read the table only. Don't read everything in the drag add. Sometimes you will need just to look what is the type of the study. Is it case control? Is it clinical trial? Just very quick. And if it is very long and you are running out of time, also you can read the conclusion. Otherwise you don't need. So read just the last lines, look at the table, understand what is the figure in front of you, whether it is a figure or a diagram, or if it is a table, understand what is it talking about, what is the association that you are looking for. Sometimes you will have like data here and data here and also data here, but the data here, it's for example the risk in this group and the risk in this group, and here they already give you the relative risk, so you don't need the single data here. So all you need is to look at the last one that will show you the relationship between these two data, which is the relative risk. And look for the p-value. You will see the p-value, whether if it is you have p-value or confidence interval. And look what you are looking for. What is the association? Is it the association between the amount of exercise and the decreased incidence of the MI? What is the table is talking about? You are measuring an association between what and what. And then no need to read the table, especially if it is very big table. If it is small, that's fine. If it is small, just quickly look at the confidence interval and all the data. But if it is a big table, no need. With too much information, no need to read just understand what it is. And if there are stars in between the data, or if there is like alpha in the table or in the diagrams, if just look down, what does it represent? What does star mean? Because sometimes they will tell you star or alpha, it means these values are statistically significant. So you might find here a value and you will pick the answer that shows that this is the right answer, but there was no star on it, so which means this value was not statistically significant. So if there is any information, just go down and see what it represents. Sometimes inside the table they give you like they will give you like SD, some letters that you don't know what it means. Sometimes they will tell you that SD stands for stroke deviation or whatever it is. Okay, sometimes they will tell you what this represent and what this represent here. Sometimes no, you have to go back to the question. Don't read all the drag add. Just go and check what does this represent and what does this represent. For example, I can give you like a table and but just say A1 here and A2 here and A3 here. Okay, I don't know what is A1, A2, and A3. I will just go back and I will realize that A1 represent that you are exercising 15 minutes. A2 represent that you're exercising between 15 minutes to 20 minutes. And A3 represent you are exercising more than 30 minutes. So if the letters inside the table, you don't know what it is, just go quickly and see what each category represent. Because in the answers itself, like one of the answer, I will tell you, exercising 15 minutes is associated with improving mental health. But how would I know if I don't know in which table I will in which column I will look? So if I know that A1 represent this table and this one, so I will just look at this, at this data or at this data. I will know to where I look. Same thing, the second answer, it will say there is a statistically significant association between exercising 20 minutes and decreasing the incidence or improving the mental health. Which one I'm gonna look to if I don't know what is A2. So I will go to A2 column and I will see if there is an association between these two, and I will look at the p-value, and based on that I will eliminate. So number one, read just the last line. Number two, go to the table, understand what is it about, see if there is any data represented here, and if there is no letters or something that you don't understand what does it represent, go back and check it, and then eliminate. Read answer 1, go back to the table, eliminate it. Read answer 2, go to the table, eliminate it, so on and so on. And usually in all these things that we were talking about, case control studies, cohort, relative risk, odds ratio, hazard ratio, usually we are talking always about an association. We call it a measures of association. So any answer that has the word this result in this, or this definitely causes this, or this will lead to this, these answers, without even going back to the table, you will just eliminate them. The only time that you will say that there is a causality relationship, there is a table, but I don't think it is high yield. In new word 3, there is a table that shows you that when do we say that there is causality, but the most important element in that table is the only time that you can say in the answers that there is a causal relationship when you are talking about duration effect, or what we call dose effect or volume effect. So if I tell you that the hazard ratio between like smoking and lung cancer, it was after 5 years is 1.2, and then after 10 years it was 2, after 30 years it was 5. So over the years you are seeing increasing, you're seeing increasing in the hazard ratio or the relative risk. Okay, so because you're seeing increase over the exposure, as you are exposed to more over the years to smoking, this is the only time or the duration or dosage effect, or what we call the size effect. So this is the only time that you can cause that there might be a causal relationship between the exposure and the analysis. So always look for the answer that shows you the word may, which is a probability. Even if you have a statistically significant association, this is still a probability. So you will say this, there may be, or there could be, or there can be an association between this exposure and this outcome, and it is statistically significant. There may be like a statistically significant association. So any answer that shows causation, remove it. The only time that you can see a causal relationship when you have a dose effect.
Thank you very much. You said the duration and dose effect, and what was the last one?
Volume sometimes. Anything that shows more exposure, that like the volume of the exercise or the amount of the exercise. So if I'm telling you, you are exercising 15 minutes per day versus 20 minutes per day, this is the volume of the exercise or the amount of the exercise. Anything that shows you as you are increasing the timing or the dose of the exposure, you are having higher and higher relative risk or value. This is the only time that you will have, you can say that there might be a causal relationship between the exposure and the outcome.
So much. Jazakallah khair.
Okay. Anyone else has any question?
No.
Okay, guys. Thank you so much for.
Thank you so much, Dr. Huda. Thank you.
Yeah, sure.
Thank
Good
you so
luck
much,
for your
Dr. Huda.
residency.
Thank you so much.
Yeah, wish
Thank you, Huda. I really, really am thankful to you.
Yeah,
Thank
I'm
you for
really
giving me
thankful
this
to
chance.
you
Yeah.
as well.
Thank you.
Yeah.
Bye.
Thank
So, Dr. Huda, that is we're just gonna have one day, right?
Yes, yeah.
Okay.
Mhm.
Okay. Thank you so much, Dr.
Thank
Huda.
you so
Thank
much.
you.
Thank you so much. Good
Thank
luck.
you. Good luck for everyone. Yeah.
Thank you. Yeah, thank you.
Okay, yeah. And if you have questions, just add it in the group. If I have time, I will answer it, or you can help each other, guys.
Okay. Thank you so much, Dr. Huda. May Allah reward you for doing.
Thank you,
Thank
guys.
you.
Okay. Enjoy your day. Bye.